So we left off on Friday talking about how arterioles especially can alter their diameters. And as they alter their diameter, they change the pressure inside those vessels, and that controls where does blood go, right? As they dilate and the pressure falls, the pressure gradient between aortic pressure and what's going to that tissue gets bigger, so more blood goes. When they constrict, the pressure rises, it shrinks that gradient, less blood goes there. Okay. So what we're going to start talking about a little bit now, because it will become important as we talk about the exercise responses, is there are several ways that we can give input to that smooth muscle that lines, there's outside those sort of circles around those arterioles to tell it to contract or relax. Okay. So the first one is called auto-regulation. Auto-regulation. And what happens with auto-regulation, okay, is as blood moves through a vessel, it creates friction along the endothelial layer, that inside layer of cells. So everybody do this, okay? We're gonna go way old school back to my youth, okay? All right, you see your hands. All right, together, rub. Mr. Miyagi style, Karate Kid. This, okay? You guys feel it getting warm in there? Yes. Okay. Keep going. Keep going. You are creating friction between your hands. Stop. Okay. You're creating friction. All right. You may not think of it in that way, but remember, blood is water with a bunch of cells in it. Okay. My wife got out our pressure washer this weekend, which we've had for like a year. I got her as a birthday present. This is what you buy each other when you're in your mid-40s. You're like, ooh, what do I want? I want a pressure washer. We probably didn't get one that was powerful enough because it didn't work as well as we wanted. But anybody ever seen a thing where they do something called sandblasting? It's basically water with a bunch of sand, with some sand particles in it. Okay. And so any of you who have ever like been to the beach or done anything, you walk around and there's sand, like the sand creates friction and it can scrub some of like your skin off. You take a sand blaster and you like shoot the water with the sand at a car or at something, and it strips the paint off. Okay. Because those granules of sand create sort of roughness and friction at that particular velocity. Well, in essence, your blood operates in the same way. Okay, it's a fluid with a bunch of cells in it, and so as the velocity of movement of the blood goes up, those red blood cells create friction against the endothelium. Okay. As they create friction, the endothelium releases something here called nitric oxide. Okay, nitric oxide. Nitric oxide signals to the smooth muscle in an arteriole to relax. As it relaxes and the diameter gets bigger, the velocity of the blood going by goes down, which means that there's less friction from those red blood cells brushing against the endothelium. So this is an idea called auto-regulation. Okay, auto-regulation. And so from all of this, as blood velocity in a tissue increases, because cardiac output is going up in these things, that local tissue will tell those arterioles to dilate. So part of it is through velocity. The other part that adds on top of that is increased oxygen demand, potassium, hydrogen, these kinds of things in those tissues. Those are metabolic byproducts. Will basically tell the arterioles in those tissues dilate. Okay. Bring more blood here, slow the velocity down. That's good. Okay. So that's auto-regulation. We talked about extrinsic neural control last week. That's the idea of sympathetic nervous system response. Epinephrine, norepinephrine generally cause vasoconstriction, right? You get stressed and we vasoconstrict, especially to liver, kidneys, stomach, intestine. Okay. And I think we also illustrated the response that in some tissues, like your skin, right? If we stress any of you out, we could make your face flush, make you, right? If you were embarrassed or something, we can make your skin blood flow go up. So that same epi and norepi does not cause vasoconstriction in every arteriole, but it does in most. Okay. And so these arterioles have receptors for epinephrine and norepinephrine. And so alpha receptors for epi and norepi cause vasoconstriction. Beta 2 receptors for epi and norepi cause vasodilation. So certain tissues like your liver and kidneys and stomach and things have a very high concentration of alpha receptors. So when you get a sympathetic nervous system response, you get constriction in those tissues. Other tissues like your skin, skeletal muscle to a lesser degree, have more beta 2 receptors than they do alpha receptors. And so their response is to get vasodilation from the release of epinephrine. Okay. And so what normally happens is we release this epi and norepi during exercise. And for skeletal muscle, there's more alpha than beta 2s. And then for all the splenic region, there's way more alphas. You get this constriction response from the epinephrine and norepinephrine. And then the skeletal muscle that's actively contracting autoregulates and overcomes this constriction. And so the net is vasoconstrict to the regions that aren't active that we don't want blood to go to, like our splenic regions, and vasodilation or relaxation, active skeletal muscle. So that's how we get all of this blood to go just where we need it. It also goes to the skin, right, because of the beta 2s in the skin, so we can dissipate. Right. That's how we control vessel volume. And that's how we control the blood flow response, or where the blood goes during exercise. Okay. All right. I'll come back and show a little bit more about that when we talk about the response. So we're going to talk about blood now. Blood to me may be my favorite part of the cardiovascular system. Most people don't talk about or think about blood in the right way to me. It kind of gets the shaft a little bit. Okay. Blood is the place where we transport oxygen and carbon dioxide. Blood is the place where we transport free fatty acids and glucose. Okay. So blood is in some ways a key component of the metabolic system, because it brings us oxygen, it rids us of CO2, and it brings us our substrate. Blood also helps us regulate body temperature. Without the plasma in your blood being lost via sweat, you'd all be dead. Okay? You'd all be dead. You don't sweat, you'll kill yourself within 45 minutes of starting to exercise. Your brain will literally cook. Okay? So it plays a big role there. And it also helps us to buffer lactic acid, acidity. Okay? So blood is really, really, really important. We talked about blood volume last week, that all of you guys have a different blood volume. It's mostly related to body size and state of training, although as it starts to get a little bit warmer, when you do more things outside, you'll actually make your blood volume go up as you become acclimatized to the heat. Okay. But when we look in your blood, blood is made primarily of water. So somewhere between, right, 45% of your blood is water. I'm sorry, 55 to 60% of your blood is water. And then the other part is what we call hematocrit. And hematocrit is cells. Most of those cells are red blood cells, about 99% of your hematocrit is red blood cells. Okay, and then less than 1% are white blood cells and platelets. The things that help us from an immune standpoint and things that help us from a clotting standpoint. Okay, but the blood is water and red blood cells. And we'll talk about in the coming slides what is unique about red blood cells, why are they so valuable and helpful to us. But I also want us to call attention to some of the things that go on in the plasma. The plasma is where the free fatty acids are. The plasma is where the glucose and the carbohydrates are. The plasma is where the hormones that are going to get moved around exist. The plasma is what we use to sweat. Okay. Having more water in the blood maintains blood pressure, which is good. It's cardiac output. So we have a very large ability to move the water in the blood around a little bit, but it plays a really, really key function. Okay. Okay. Let's talk about red cells. We call red cells erythrocytes. I'm sure you guys have seen pictures and learned all about this in human phys. But the big function of a red blood cell, the reason we need red cells, the reason they're so valuable to us is they are wildly attracted to oxygen. Okay. So within a red blood cell, we are going to have a molecule called hemoglobin. Hemoglobin contains iron. Okay. Iron has a very strong positive charge, which makes it very ionically attractive to oxygen. Okay. By having hemoglobin, every hemoglobin molecule binds 4 oxygen molecules. 4. Okay. There are roughly 250 million molecules of hemoglobin in one red blood cell. You can bind 1 billion molecules of oxygen on every red blood cell. Okay. So then you can imagine that you have hundreds of millions of red blood cells. So you have trillions and trillions of molecules of oxygen that are being bound. Okay. By doing this, it increases the oxygen carrying capacity in our blood by hundreds of times compared to what we could just dissolve if all we had our blood was just water. Okay. So having these red cells dramatically increases our ability to carry oxygen, which dramatically increases our metabolic capacity. Okay. So that's the big deal with all of that. Okay. Anybody anemic? My wife is usually mildly anemic if they check. They give you iron usually as a supplement. Take a supplement if you're anemic. It mostly because of body size tends to be much more prevalent in women, individuals that are smaller. My wife is anemic. She takes the iron, which is meant to then provide sort of more hemoglobin and stuff, help to promote red blood cell count and those things. Like very more. Okay, so that's why that's something that happens. Okay. The single best way to become a better endurance athlete is to have more red blood cells. Period. End of discussion. I give every one of you a pint of O negative blood today. Your VO2 max goes up immediately. Because of all of those red cells, all of that capacity to carry more oxygen, makes your VO2 max go up. Okay. And so, you guys know where red blood cells come from in your body? Where do we make red cells? Bone marrow. Okay, bone marrow. There's a hormone that stimulates the bone marrow to make red blood cells. Guys know what that's called? Lance Armstrong's favorite thing. I know. It's released from the kidneys, weirdly enough. Called erythropoietin or EPA. And EPA. So if you want to be a better endurance athlete, You've got like 3 weeks until the Oklahoma City Marathon. 2 weeks. Right? Get some EPO today. Start making those red cells. And we'll get better. Okay. Now, I said that in the previous slide, most people are about 60-40 or so. Your hematocrit percentage is about 40%. Ranges from like 35 to 45% of your blood volume. People that take EPO can get to like 55% red cells. And then your blood becomes like Guinness or motor oil or something. It's super duper thick. Okay. And you get blood clots released because when you lay down at night, blood moves really slowly. So that can be a real problem. So we'll talk more about EPO when we do aerobic Ks. We'll talk a little bit more about EPO. We'll talk about responses to aerobic training, but that's the big deal. Okay. Knowing your hematocrit percentage, which we can do from a finger stick, can be very, very valuable for us in those ways. Okay. All right. We're now going to shift into what are the responses to exercise. They're looking pretty tired, guys. What's going on this week? Do we need to stimulate and induce some cardiovascular responses to some exercise? You guys want to do some squats or do some jumping jacks or something? But I just want you to know what these things are. We're going to walk through each one of them. You've had them all before. They're very self-explanatory. Okay. As you exercise, cardiac output goes up, which means stroke volume goes up and heart rate goes up. So we circulate more blood. Okay, that's number one. Cardiac output goes up. Blood flow to the skin goes up. Okay, your skin becomes somewhat flushed. This is meant to help us remove that heat that we are making from those muscular contractions, from that metabolism. We get decreased blood flow to the kidneys and the spleen, especially, and the digestive tract. So we shunt blood away by vasoconstricting the arterioles to go to those areas, and then we vasodilate to skeletal muscle and the coronary arteries, right? You get a little bit of an increase in blood flow to the brain, but it mostly stays the same. Brain needs X amount of flow always, okay? Always. Anytime you faint, for the most part, it's because your brain didn't get enough blood flow. And the response is fall down, right? Stop doing whatever we're doing, fall down, remove the effects of gravity, and try to maintain brain flow. And then blood pressure goes up. Systolic pressure is going to go up. So the driving pressure in the left ventricle or in the aorta is going to go up, which helps us move more blood around, which leads to this increase in cardiac output. Okay. The goal during exercise is to balance, okay? Maintain blood pressure. If blood pressure falls, that's also part of the reason why you faint, okay? Pressure needs to be maintained or increased, and then make sure we get adequate flow to the muscles, the heart, and the brain to allow us to exercise, okay? At all costs, brain flow will be maintained, as will cardiac flow. As exercise progresses, though, if you're willing to push really, really hard, you can begin to send blood away, pull blood away from the skin and direct it to your muscles, okay? Which can, when it's hot outside, end up being very, very dangerous. That's kind of the big goal here, okay? Balance pressure with sending our cardiac output to the heart, the brain, and skeletal muscle. Okay. So the first thing that I had on there was cardiac output goes up, right? This is the amount of blood that we present or that flows by all of our other tissues in a given minute, right? So it's going to go from 3, 4, 5, 6 liters per minute of cardiac output at rest to about 4 or 5 times that, okay? 20, 25, maybe into the low 30s cardiac output. So a lot of blood moving by tissues every minute. It goes up because heart rate and stroke volume both increase. We'll get into how they increase in the next couple of slides. Okay. But of those two things, heart rate increases all the time. up to its max. It goes up a little bit, it goes up a little bit more, and it continues to rise basically until we reach max exercise. Stroke volume goes up for a little bit. And once you clear kind of jogging, stroke volume flattens out and levels off. Okay, it flattens out and levels off. So the response to those two things is going to be a little bit different. And I'll show you guys some pictures and we'll dig into that in the next couple of slides. Okay. Okay. Here is the cardiac output response to increasing running speed on a treadmill. We're basically putting someone on a treadmill and you're going to do a couple of minutes at, this is like 4.5 kilometers per hour. Okay. You can imagine, right? In science, we use the metric system. I don't know what 4.5, that's like 2 miles an hour or something like that. There, we work our way up until we're going faster and faster. So it's basically walking to maxing out doing a VO2 max test. Okay. Every couple of minutes, it just progressively increase treadmill speed. So there's this roughly linear increase. As work rate, as force of contraction, as metabolism increases, there's this corresponding direct increase in cardiac output. More blood circulating to present more oxygen and glucose and free fatty acids and hormones to that working skeletal muscle. Okay, so relatively linear increase. Okay. Why is it mostly linear? Well, it's mostly linear because heart rate goes up in a relatively linear manner, and that drives a lot of our response. Okay, so we get an increase in heart rate during exercise first by removing parasympathetic input from rest. We withdraw acetylcholine, that raises heart rate. Then we start to dump epinephrine and norepinephrine into the system. It binds on the SA node and drives faster contraction. Okay. That goes up basically until you reach your age predicted max heart rate. For you guys, it's going to be very close to 200. Stroke volume increases up to a point and then levels off. It increases because of increased preload. Okay. Question. What's vagal tone? Vagal tone. The vagus nerve is the parasympathetic nerve. That's what signals the release of acetylcholine. So vagal tone. Did we talk about my hatred of the word tone? Yes. Okay. That's a proper use of tone. Not like I want to look toned in my muscles and those things. But if you think of tone as, am I getting some release or not? Am I getting a little bit of constant release, or as tone goes up, I get more and more? That's what we mean. So removal of vagal input, increase in sympathetic input, or increase in sympathetic tone. Okay. Stroke volume goes up because of an increase in preload. We get an increase in preload mostly from increased venous return. Okay. As muscles begin to contract, we squeeze more blood back to the heart. You begin breathing more deeply, so you increase that area in your chest cavity as you breathe more deeply. That creates more suction and pulls the blood back. Most of it is due to increase in venous return. That's preload. You get some increase in contractility. That comes from two things. One, from the increased preload, there's more stretch. There's more Frank Starling, basically stretch, which is still more forceful contraction. And the second is from an increase in norepinephrine, causing the left ventricle to contract more forcefully. Okay. So more blood in, a more forceful contraction, and as we vasodilate out in the skeletal muscle, we're going to lower resistance to flow. We're going to lower in diastolic pressure basically out of our tissues, which allows a little bit more to go out. So basically what we're doing is we're shrinking afterload in doing all of this. Now, the problem we have with stroke volume is we can only get so much blood into your left ventricle. It's only so big. There's only so much venous return we can handle in the left ventricle, right? The cup is only so big, and at some point you can't pour any more blood into it. It's also only so strong. There's only so much we can do from a contractility force standpoint. And so at some point, it cannot get any more blood in, and it cannot contract more forcefully. Max those two things out. And so basically when that happens, stroke volume levels off and plateaus. And for most of you guys, that happens between about 50 and 60% of VO2 max. So a very brisk jog, a very brisk walk to kind of a nice easy jog. Okay. And so once stroke volume plateaus, the only way to further increase cardiac output and thus increase VO2 is to increase heart rate. So that's why, especially the top end of the cardiac output graph looks like the heart rate graph. Okay. Here is heart rate graph against that same treadmill intensity. Very, very linear. As you go faster and faster, and you get more forceful contractions and you need more ATP, heart rate goes up in a very linear manner with VO2, with work rate. Where's my stroke volume graph? Here's the stroke volume graph. It goes up initially and then it flattens off. Okay, up, flatten off. Okay, so let me back up and we'll talk a little bit about what else is happening during with the heart rate. I mentioned this last week, but I really like this visual because I think it drives the point home. Okay, so you guys remember when we talked about stroke volume regulation that one of the other things that contributes is heart rate. And so what you see on the top is what your heart rate is doing right now. Okay, it's 75 beats per minute. It's at rest, basically. And you will note the red part is ventricular systole or contraction. And then the white part is ventricular diastole. So an entire heartbeat takes about 0.8 of a second. You spend about 1/3 of a second in contraction and about 1/2 a second in relaxation. Okay. During high intensity exercise, so heart rates of about 180 beats per minute, you've shrunk the amount of time or the time window for every heartbeat from about 0.8 of a second down to about 1/3 of a second. So it has shrunk, but you will note now systole occurs faster, but it's actually a larger percentage of each heartbeat is systole compared to diastole. So as diastole shrinks, filling time for that venous return and thus our capacity to get a larger end diastolic volume is going to shrink. Okay. And so we're kind of competing basically in the midst of this to be able to fill out the whole line. Okay. So that's one of the reasons at very high intensities that we may see a little bit of a dip in stroke volume is diastole becomes so short. Okay. All right. So there's the stroke volume graph. What I want you guys to do now, we talked about why it plateaus. Okay. Let me show this heart rate. We'll go back to the heart rate graph. All right. Here's where we're going to talk about our tracker. Okay. Again, show of hands. How many of you guys have some kind of heart rate monitoring device? Like in your watch, you have an Apple Watch or a Fitbit, or even a fancy heart rate monitor that you wear, you kind of wear here around your chest. How accurate do you guys think those things are? That's my question. Who wants to guess? Do you think we know how accurate that is? All I will tell you all is that your daily caloric expenditure that your watch tells you is based upon your heart rate measured across the day. So, do you think it's accurate? You know, saying no up here. Why not? Why? I should have worn my Apple Watch. Of course, I did it today, but it's right here. Right? Most of you have a watch that sits like this. How does it measure your heart rate? You guys know? What's it doing? It's taking your pulse. How do you take your pulse? So if I do a traditional way, I take my pulse here. What am I feeling? What's actually happening? I'm feeling the blood flow going through my arteries close. When you feel your pulse here or something, what do you actually, it's a physical like signal, right? You can feel it. So what are you feeling? Make me do it, Pat. Somebody say something. But
It's like pumping the blood back to the heart.
it's pumping up the blood, right? But like, what's happening? What is it that I'm feeling? It is the blood that's being pumped, but what am I feeling? When you feel it go boom, boom, right? Like you don't hear it, like you had a stethoscope on, you're feeling something. So what is moving that you're feeling? It is blood, yes. It's also something else. It's the pressure change that's pushing blood out. The walls of the artery, it's probably more of a vein that you're also feeling. What you're feeling is that pressure wave deflection causing that vessel when systolic pressure comes through to go boom, boom, boom. Okay? And so part of what happens, right, is that. But a lot of the watches, rather than feeling that change, they shine infrared light in. And what they're doing is they're looking for sort of these changes in the infrared light signal, like in your capillaries and those things. Okay. And they're using that sort of quick increase in sort of the movement of the red blood cells, which the infrared light mounts, hemoglobin, to try to figure out when your heart is. Okay. It's a strange technology. Okay. What I can tell you guys is that if worn properly, they're usually pretty accurate. Within, I don't know, 3 to 5 beats per minute if it's worn and seated correctly. So it's not that far off. Okay. And they compare those to like an EKG. They'll test them, they'll put the EKG on, they'll measure the electrical signals, and they'll find the R waves, they'll find the ventricular contractions, and they'll compare them. So what we do know is they're better at rest than they are during high intensity exercise. So it kind of, as heart rate goes up, the validity or the accuracy begins to deteriorate. It gets a little wide of the hand on all of those things. Okay. But that's why we track heart rate during exercise, is this, okay? Of all of our indirect ways to measure metabolism, measuring your heart rate is the easiest way to be reasonably accurate. Okay. If I can't measure oxygen consumption, if I can't measure the air you're breathing in and out, measuring your heart rate is a very reasonable scenario. Okay. That's why we tend to use heart rate to prescribe exercise intensity for aerobic exercise. That's why in Principles of Health and Fitness, you learn how to find these target heart rate zones. That's why in testing and prescription, when you're looking at people that are clinical populations, you want to pay attention to what their heart rates and all of that is. That's why we use the idea. You guys remember heart rate reserve and how to calculate intensity based on heart rate reserve and all of that. That's why we do it. Okay. That's why if you've ever been to Orange Theory Fitness to go work out, they put the heart rate monitor on you and they tell you to get into a certain heart rate zone. Okay. They don't calculate their heart rate zones as accurately as I would like for them to, but the science behind it is sound. They don't use heart rate reserve, they use percentage of max, which tends to lead to an underestimation, which is probably better in most people. But that's the idea here. So when you guys want to know how accurate are these trackers, that's the most common kind of trackers to measure heart rate. They're pretty accurate. Okay, they're pretty accurate. Okay. Questions about that? No? Okay. Need espresso shots for everybody in class. Okay, so we talked about those two things. All right. Next, so we know cardiac output goes up, heart rate goes up, stroke volume goes up for a little bit, and it levels off. This is a sort of picture and kind of a weirdly graphical graphic representation of at rest and during exercise, where is the blood going in your body? Okay, so at the bottom in gray, this is rest. At the top in the pink, that's exercise or very near max exercise. So cardiac output of 5 liters per minute versus, cardiac output of 25 liters per minute. Okay, and so the size of the organ or the tissue on there represents roughly how much blood it's getting, or kind of where it is slowed around. So, okay, what you guys will note is at rest, about 20 to 25% of blood flow is going to liver, stomach, right, intestines. During high intensity exercise, that's all the way down to 3 to 5%. Okay, the heart gets about 4 to 5%, no matter what, but 5% of 25 is much larger than 5% of 5. Okay, the kidneys get about 20% at rest and about 2 to 4% during exercise. Okay, bones get a little bit of blood flow. They get even less during exercise than at rest. Your brain gets about 15% of cardiac output at rest. That falls dramatically during exercise to 3 to 4%. But if you do the math, 15% of 5 works out to be about the same as 3% of 25. So the brain gets the same amount of blood. Okay, it's just a smaller percentage of that larger cardiac output because the brain doesn't have to work harder when you're exercising. Skin, okay, skin's getting, right, as you can see, there's not a number up on the top. That's really, really strange. Skin's getting 4 to 5% at rest. It gets a little bit more than that during exercise. The big change, though, is skeletal muscle goes from about 15 to 20% to 80 to 85%. So the big things that happen during exercise, blood goes away from the splenic regions and it all goes to skeletal muscle. That's the big deal. Okay. Vasoconstrict to liver, stomach, intestines, and kidney. Vasodilate to skeletal muscle. That's the big take home. Okay. These two graphs show the same idea. The same idea. Okay. What you see here on the left is relative, or the percentage of total cardiac output that goes to each individual type of tissue. And so every color on here represents a different tissue group. Okay. This graph on the left shows what I just showed you in the slide before. Here is rest, light, moderate, and maximal exercise. The previous slide showed rest and max. But what you can see, right, is that kind of dark, kind of browny red at the top. Okay. That is kidneys, liver, stomach, intestines. So that's splenic blood flow. And then the other one to keep in mind is this kind of strange, reddy, almost burnt orange, I'm sorry, is skeletal muscle. Okay. And the big takeaways, right, is that at rest, a large percentage of cardiac output is going to splenic, much less so to skeletal muscle. And then as exercise intensity increases, you will note the orange gets bigger and the kind of browny red gets much, much smaller. Kind of less color gets smaller. Okay. On the right here, it's the same data, but it is showing kind of what is happening in an absolute sense. So here's 5 liters per minute versus 12 versus 20 versus almost 30 on the far right. Okay. And then within that large portion, you can see kind of the relative percentages within each one of these. And so again, total cardiac output goes up a lot as intensity goes up, but within that cardiac output, the same pattern occurs. Splenic percentage shrinks, skeletal muscle percentage gets bigger. Okay. This one I think illustrates really nicely how, see how the blue stays the same and the green goes up a little bit, but stays relatively the same. That brain and heart blood flow are basically the same. And what we're switching the flow around from is going to be splenic, muscle, skin. Okay. Does that make sense, guys? I know it's a lot of ways to show the same data, but the real take home with where does the blood go is total output goes up and we shunt the blood away from splenic regions to skeletal. That's the big take. All right. Okay. So I think one of the last things that I mentioned was that blood pressure increases during exercise. We have to be careful. What we need to say is systolic blood pressure, so left ventricular driving pressure increases during exercise. This is mostly driven by an increase in the force of contraction of the left ventricle. Okay. And so by doing that, it increases aortic pressure, which means we start that blood flowing around. The pressure where it starts is higher, which makes the gradient between the aorta and any tissue bigger, which will force the blood to move around more easily. Okay. That's the big thing. A thing to note. Diastolic pressure. So the pressure in the aorta, which reflects the pressure in the left ventricle during filling, basically stays the same in healthy people during exercise. Okay, it stays the same, which indicates to us that our kind of total resistance in every place is going to be not too different. Okay, if diastolic pressure increases during exercise, for those of you in tested prescription, that's an absolute contraindication to exercise. You need to call 911 right now if diastolic pressure begins to increase, because you're about to have a heart attack. Okay? So diastolic stays the same. Sometimes it may actually go down a little bit, which is good. Systolic increases. We mentioned last week about the Valsalva. You can get this giant exaggerated pressure response when you hold your breath, contract the pelvic floor muscles and everything. Here, you sort of tighten everything up, tighten your abdominals so that you don't squish your internal organs. During Valsalva, we see blood pressures up to like almost 500 over 350. Giant exaggerated response. Okay. That's why never have a person with high blood pressure hold their breath during exercise. They're going to get this, and they can have a much greater chance of bad things happening. Okay. What you see here, okay, there's a red line and a green line, and then there's the top ones that are triangles and the bottom ones that are circles. Look at the green ones to start with. Okay. These triangles represent systolic pressure. The circles represent diastolic pressure. So here's a person who is sort of at risk of hypertension. They're at about 120 over 70. At some point, we'll decide that normal blood pressure is pre-hypertensive. They've changed it about 5 times since I've been doing this in the last little more than 20 years. Okay. We're all basically pre-hypertensive at some point. And so what you will note is as the percentage of VO2 max goes up, systolic pressure rises, diastolic pressure stays mostly the same. Okay. It would maybe a little bit at max where some weird things begin to happen, but it's mostly constant. Okay. What you see in red is the same response, but the green represents riding a bike normal with your legs. The red represents riding a bike by doing arm crank, cranking your arms like this. What I want you to note is that the red response is more pronounced. You get a larger increase in systolic pressure during exercise when you do arm crank exercise compared to leg crank or leg cycle. You get a larger increase when you do exercise with a smaller amount of muscle and a larger amount of muscle. Okay. So again, those of you that work in PT and OT clinics, when you have the older folks come in and you have them warm up by doing the arm crank cycling, that is inherently more dangerous to people that are hypertensive than leg cycling, because they get a more exaggerated blood pressure response. This is all related to your legs are way bigger than the arms. So when you vasodilate to the leg muscles, you lower peripheral resistance to a greater degree. So the systolic pressure response is blunted. So more blood goes here, bigger, sort of the pressure response is less exaggerated. When you do small muscle mass, you vasodilate just to your arms. And so the peripheral resistance stays higher and you get a more exaggerated response. Okay. But that's what the normal response looks like. Okay. So, oh dear. Okay. How much time do I have? Oh, okay. We'll talk really quickly about plasma volume, and then we'll clean up AVO2 difference and FIC on Wednesday. Plasma volume. You shift the water in your blood around during exercise. That's the pump. Okay. You drive water out of the blood into skeletal muscle, okay, due to increases in oncotic and hydrostatic pressure. That leads to what we call hemoconcentration. So your hematocrit percentages, the plasma, as the water goes into your cells, or as it is lost via sweat, blood volume shrinks a little bit, so your red cells account for more of that blood volume. It's actually a positive. Okay, so that's what's going on. That's what's going on. We'll finish this Wednesday. We'll start the pulmonary stuff. Ty is putting up a take-home assignment on hormones today. There'll be one on the cardiovascular stuff by Wednesday. Keep working on those. All right. See you Wednesday, guys.
I'm like on the last page, cardiovascular, so I can have them both.